Hi, my name is Nabil Arrach. Today I'm very happy to present at this one-day certified online course along with my other two colleagues, Dr. Rajni and Dr. Santiago Mine. Today is going to be more than just genetics. We will also talk a little bit about diagnostics. My topic is non-invasive embryo screening using AI-powered metabolic assay. That's it, the NEMA assay. So to give a little bit of background, PGTA is still the gold standard with a correlation of approximately 95% that could be considered the accuracy, although it's very hard to calculate accuracy in PGTA since you cannot evaluate embryos that are not transferred or embryos that fail implantation of pregnancy due to other reasons, such as endometrium, lining, and other factors, patient factors. The mosaicism in PGTA is still a problem, as we know. There's a lot of controversy, very difficult topic to address with patients. There are companies that report low-level mosaicism, high-level mosaicism. Mosaicism in nature is probably much lower than reported by laboratories. Our estimate is probably 0.5% among embryos. The implantation rate with PGT is about 70%. And the pregnancy rate ranges from 50 to 60, depends on the clinic, on the QCs and patient population, etc. And depend if they are using PGT or not. PGT obviously increase implantation and pregnancy rates. The drawback of the PGT with biopsy is that the biopsy is a very complex process, that it's very difficult to manage in clinics where there's a lack of laser or there's a lot of lack of training and expertise in biopsy. But also biopsy is inefficient because you have to pull a piece of that material from the embryo to estimate the chromosome copy number. So it's not an ideal situation. It can introduce stress to the embryo and can also be time consuming. It adds cost to the patient because biopsy has its own cost plus PGT testing. And potentially damage into the embryo because, when you are pulling material, depends on your level of expertise, freezing, thawing, biopsying, all that introduce additional stress to the embryo that may not be ideal. And add to that the challenge that we see with mosaicism. A few years ago, the non-invasive PGT emerged as an alternative, an attractive target for the laboratories to explore. The problem with that is when you look at almost now 7 years of testing, publications, validations among all laboratories, the accuracy of non-invasive PGT is still in the 75%, looking at the overall literature. And that is not reaching the level of accuracy needed in a clinical test. And so obviously this is going to impact the clinical outcome. It will impact the patient experience and other things. Plus, if you look at non-invasive, there's about 10% material contamination to lead to erroneous results. And, contamination is typically a big problem in material or specimen that has very little amount of DNA. So improvements, this is improvements in general could be increasing the accuracy, reducing the error rates due to contamination, and probably coming up with a consistent media, so media that to bring more consistency in the testing. Right now, there's a lot of variability between embryologists and between within the same embryologists, between samples. There's a lot of variability in the sample because the collection method or the sampling method relies on the presence of DNA, which is not always the case. There are situations where the embryo does not release enough DNA in the media. Then, after the non-invasive limitation that we have seen, progenesis has taken another route, which is, can we look at the non-invasive test from a metabolic profiling? At the end, it's a very different perspective because you look at metabolites and metabolism. And so even if you have a very good way of assessing chromosome copy, it's still not enough, because that is an information that affects syndromes and affects, sometimes aneuploidies or segmented aneuploidies that may affect the implantation and pregnancy rates, but it does not really address the biology of the embryo. And metabolic profiling gives us that perspective of looking at how the embryo does from a metabolic profiling. Does it metabolize all the nutrients? Does it use the correct pathways, metabolic pathway? Does it release the right hormones, cofactors that can enhance the implantation and pregnancy? And so there are lots of metabolites one can look at, and those metabolites could be identified and classified as a library so that it makes the test a little bit more straightforward, because if you have libraries, you can just establish a signature and then follow that signature to classify embryos between metabolically fit or non-fit embryo. And that requires a lot of analytics, and requires AI. So back to the test itself, the chemical test, it uses a mix of a matrix and specimen, a non-invasive media where the embryo has grown. And that mix will allow the ionization of the sample. So when the sample is now bombarded by a laser, it will release ions that, when they travel through the channel of the equipment, the time to fly will determine the mass and charge. And so you can imagine with a sample, you can get thousands of peaks. Each peak is a different molecule. And sometimes two peaks may be the same molecules, but different fragmentation of the same molecule. And so when you look at this profile, you really have to have a way of distinguishing between between the molecules, and also between the profile that is more conducive to implantation and pregnancy versus the one that is not. So we are really defining or redefining diagnostics today by incorporating AI within our diagnostic tools. And so, you can still use genomic tests, whether that is a PGTA or non-invasive PGTA, along with metabolic profiling. But all this data is really not analyzed using simple algorithms. There is a lot of AI components to it. And so if we look at a single profile of an embryo growing in culture media, here you see two colors. You see yellow and gray. One is the embryo, the other one is the media without embryo growth. And you can see that the profile are very similar. They overlap in many places. There are two considerations to take into place here. The first is the peak MZ, which is the x-axis, and then the intensity of the peak, which is the y-axis. Both of them are important information that play a role in the classification of the sample. And so this is an example where you see the two peaks, the two patterns or profiles of media and sample overlapped, one in blue and the other one in green. And you can see that in certain situations there are peaks that are present in one but not in the other, or the intensity is very different. And so using spent media metabolic profiling, we have done a validation with 200 samples, of which 150 were analyzed using MALDI mass spec, and 50 were used to be analyzed with a high resolution mass spec to identify the exact molecules that could contribute to a library for future selection. For the 150 samples that were analyzed with MALDI, the data was analyzed, extracted, normalized, and then subject to machine learning to identify patterns that are correlating with positive outcome. And here, positive outcome is euploidy and aneuploidy. We have used a model where when you have data training and then evaluation, then retraining, and then prediction. And we have used different models from random forest to logistic regression, all the way to dense neural network. Each model gave us different prediction, but overall the prediction was about 90%, meaning that we can predict if an embryo is euploid or aneuploid using media with metabolic profile with a 90% accuracy. Again, this is a small study. We are currently working on a bigger study to look at not just euploidy and aneuploidy, but also implantation in pregnancy. So if you look at the side-by-side comparisons between non-invasive PGT, and the NEMA test, the metabolic test, the first thing that comes into mind is that the PGT requires consistent presence of material. When talking especially about the non-invasive PGT, it requires the presence of DNA in the media. And that is not easy to accomplish. You really have to re-engineer the culturing system of embryology to try to conceive the same amount of DNA in the media, and that's not an easy task. That's why PGT non-invasive is really not adequate for embryo screening at the moment. Another problem is obviously maternal contamination. Here, when we say gender diagnosis, we're not referring to India. This is for other countries where gender is allowed. Obviously, in India, gender will not come into question or into interrogation in the first place. And not just India, but there are other countries like Canada and other jurisdictions that prohibit gender selection. Then we have the rate of inconclusive results. So when you look at inconclusive results, there is a high rate in non-invasive PGT, slightly lower than PGT-A with biopsy, which is about 3%. But the NEMA really does not have much. And the reason is because the NEMA test has dozens and sometimes over 100 data collection from the same sample. So really imagine if you have 100 biopsy from an embryo, would you have a non-inconclusive result? It's very hard to have that, right? Because you're doing a really good sampling method where you have a lot of data points to collect. And so even if one or two fail, you have many others that can give you results. And then the accuracy, the non-invasive PGT is in 75%, 95% plus for PGT-A with biopsy, and around 90% for the NEMA test. So in ongoing studies, our ongoing studies will include the evaluation of the NEMA test to predict implantation and pregnancy and biochemical loss. And we are also going to explore the libraries that we are analyzing to see if they are able to predict outcome. Those libraries are molecules that are present in euploid but not in aneuploid, and others are present in aneuploid but not in euploid. And so if you could also isolate molecule, identify them, molecules that are correlating well with pregnancy and implantation, then it would be an awesome, an ideal situation. So today we are redefining diagnostics, as we were saying earlier, by merging molecular diagnostics and AI. And AI comes in different shapes. There is an AI that is used within the diagnostic test as a way to analyze the data. But there is other type of AIs that are used to analyze images. For example, oocyte images, embryo images, sperm images for selecting the right sperm. And so imagine when you combine AI with diagnostics, obviously you're going to have the best way of looking at an embryo from a screening perspective. There are existing tools in sperm selection, for example. If you look at the CASA or the Mojo, those are systems that are identifying characteristics in the sperm to predict which sperm will have a better outcome based on motility and shape and the dimensions of the head, etc. There are also other tools for embryo selection, and here you can see all these bars in different colors that represent studies, correlations in studies. So those are correlation between how accuracy, let's say the accuracy of the AI of predicting the right embryo. And when you look at the entire literature, several predictive models, they are probably in the 70s, 75% or so. Also, if you compare AI to embryologists, in all these studies, it looks like AI is doing a better job than embryologists in terms of predicting the correct embryo. And so when you look at the literature in general on AI and embryo selection, it's a exponentially growing body of literature. That means there is a huge interest in AI for embryo selection and for fertility in general. So when you look at images, time-lapse is one of the best way of evaluating an embryo because you look at the growth in real time. You can look at different phases of embryos. But some other labs that don't have time-lapse have chosen to use static images, which is also another way of evaluating an embryo. Both situations rely on images only, and that's the problem with AI today. It does not take into consideration the context, the patient context. It doesn't look into age and BMI and AMH. It does not take into consideration the stimulation protocol, the type of trigger, and etc. So if you add all these contexts as integral parts of the AI, then you're going to have a better predictive value. So extracting data from time-lapse rely on measuring those 16 phases of embryo growth. Time it takes each phase is the critical information that is used by AI algorithms to predict whether that embryo is likely to be euploid or likely to implant. And so if you look at AI as it is now, there is about 75% accuracy. In some papers or some studies where they have added the context, the value or the prediction has increased to 80%. In our laboratory, we have extracted information from static images to try to predict embryo grade, something that we are trying to do to remove the bias in embryo grading. And we have obtained about 82% in expansion, predicting good embryos based on expansion, 69% based on ICM, and 65% based on TE. And we're using similar tools to score embryo for predicting the euploidy and implantation. We have used different predictive models including deep neural network, and we are trying to extract from time lapse. This is for static images. From time lapse, we're trying developing models or algorithms to extract the information from those 16 phases of embryo growth, and then using time that takes each phase to predict the best embryo possible. And there are many ways to cluster the data and many ways of looking at the data. So you could do a completely non-supervised model where you're not looking at any particular feature, or you can start to look at phases and make it a little bit more supervised. So combining genomics, metabolomics, and AI through embryo images or time-lapse is definitely the future of embryo screening. This is how a report would look like. We're working on this context or in this concept to provide enough information on the embryo to select the best embryo possible. And so you could look at these, you could look at the non-invasive PGT. If you are only doing non-PGT, non-invasive, then you can look at metabolic profiling information or scoring, and then you look at the AI using images or time lapse, and all that is combined into one single score or rank that will allow you to choose the best embryo possible. There are two ways clinics operate in terms of priority. There are clinics that wanted to move from PGT biopsy all the way to non-invasive, even if that doesn't give them the highest rates of implantation and pregnancy, because it's easier for them to operate in a non-invasive environments for one reason or another. In this case, it is possible to combine the non-invasive PGT with metabolic profile NEMA test and AI looking at images. For the other clinics that wanted to increase clinical outcome, for example, from 70% implantation to 80-85% implantation, or from pregnancy 50 to 60% all the way to 70%, then they have to use the PGT with biopsy as a background, as a starting point. And on top of that, now they can use metabolic profiling to enhance the clinical outcome along with AI. With this, I'm coming to the end of my presentation on metabolic profiling using non-invasive spent media. This is GENES. It's our yearly conference that we organize. This year is going to be June 1st to June 3rd. And it stands for Genetics, Embryology, and Endocrinology Symposium. We have about 150 attendees. It takes place in San Diego, California, and is a very, very high quality symposium. So if you have time, please let us know, or go to genes.com, Genes Conference on our website, Progenesis website, and find more information on how to attend. You can also attend virtually, either if you are in India or other countries, and we have the logistics to allow that as well. That's it. Thank you so much, and I will see you soon.